Okay, and good morning, and thank you for joining us for the CREMS webinar series. The focus of our webinar today is going to be on the comorbidity training guidelines, which will be presented by Dr. Chris Marel and Jack Wilson. And my name's Lexine Stepinski, and I'm going to be chairing the session for today. So you'll have the opportunity to ask questions at any time or make any comments that you have. We'd encourage you to do that through your control panel. So please just shoot through any questions that you have at any time. And just to mention that the videos will go in and out a little bit during the session, but hopefully what will be continuous is our voices, so you'll still be able to hear us. So if you stop seeing us at any point, just don't worry, we're still here. Okay, so we'd also like to let you know about the exciting series of webinars that we have unfolding over the year, which you can register for right now at our website, so at comorbidity.edu/training/webinars. So in May, just coming up shortly, we've got a prevention-focused webinar, which is about what parents can do to prevent teenage substance use. We also have coming up in September Associate Professor Francis K. Lampkin, who'll be talking about effective models of care for comorbid mental illness and substance use. And if you missed any of the webinars, any of the 11 topics that we've had in the past, you can access all of those webinar sessions on demand by visiting our website. So in just a moment, I'm going to introduce our speakers for the session. But before I do, just for a quick overview for those of you that are joining us for the first time about what CREMS is and what it is that we do. So CREMS stands for the NHMRC Centre of Research Excellence in Mental Health and Substance Use. And what we're all about is conducting research to improve our understanding of mental health and substance use disorders and understanding in particular how and why these problems co-occur. And so what we're also trying to do is working to develop improved strategies and conducting research to identify the most effective ways to prevent and treat these problems. So to achieve this, we work really closely with services, schools, and community groups, and this webinar series is another way that we facilitate those lines of communication. So just to show you a photo of us here at CREMS, and in the hot pink on the left you'll see Professor Marie Thiessen, who is the director of our centre. So now what I'd love to do is introduce our speakers for today. So our first speaker is Dr. Christina Marel, who is a research fellow within CREMS at the National Drug and Alcohol Research Centre, and her research focuses on improving our understanding and responses to comorbid mental health and substance use disorders in complex populations. So she's recently completed leading the second edition of the Guidelines on the Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings. Wow, that's a bit of a mouthful. Glad I don't have to say that twice. And she's currently developing an online training program to accompany the guidelines, and that's what she's going to be talking to us all about today. And we also have a second speaker, Mr. Jack Wilson, who is a research assistant with CREMS, and he's also working on the dissemination of the National Comorbidity Guidelines and the development of the online training package that will accompany them. So without any further introduction, I'd like to hand over to Chris now to begin the presentation.
Thanks, Lexine, and thanks so much for joining us today. So as Lexine mentioned, we're going to be talking about the second edition of the National Comorbidity Guidelines, which, as Lexine mentioned, is a complete mouthful, and I'm not going to repeat the title again. Which were launched late last year after many years of work, and I'm really excited to be able to be here and talk about them today. They were developed as part of a broader program of work which is being conducted through the CREMS program at the National Drug and Alcohol Research Centre. Unfortunately, Associate Professor Katherine Mills isn't able to join us today, so it'll just be Jack and myself, and I'm just getting over a cold, so I'm sorry in advance if I sneeze or cough or disappear very briefly. I'll be back. So in terms of how we've structured today's webinar, I'm going to be talking first, and we'll provide a bit of an introduction to comorbidity, which will provide a context for the rest of the talk today. I'll then talk a bit about holistic healthcare, followed by how to identify comorbidity, including where to access a range of evidence-based screening tools and assessments. I'll then talk a bit about the evidence in terms of managing and treating comorbidity, followed by the importance of involving multiple services to deliver coordinated care. And Jack will then take over and he'll talk about the online training program that we're developing. So a lot of people watching will likely be aware of what we'll be covering in the first half of the talk today, in which case please feel free to let your attention wander and rejoin us for the second half. And I'd also like to say that although the majority of the material from today's webinar is drawing directly on the second edition of the guidelines, we're not actually going to be walking through them in this talk, but really highlighting sections in particular that we think will be useful to many AOD workers. So we really encourage everyone out there, if you haven't already, to download a copy of the PDF guidelines from the CREMS website, and we'll have a link to access those at the end of the talk. Register for the upcoming online training program, which Jack will be talking about today. And if you haven't already seen a copy of or a hard copy of the guidelines, you can get in touch with us after the webinar, and we'll see if we can have a hard copy sent out to you. So first of all, what do we know about comorbidity? Firstly, as you're all no doubt well aware, we know that comorbidity is common. Mental health and substance use disorders are two of Australia's most common and burdensome health conditions, and they affect about 1 in 5 Australian adults each year, and they frequently co-occur. It's estimated that about 1 in 3 Australians with a substance use disorder also have a mental disorder, but this rate can be as high as about 75% among people who are seeking treatment. In terms of the most common mental health conditions that we see to co-occur with substance use disorders, these are typically the same as those we see in the general population, which are anxiety and depression, PTSD and personality disorders, but we also see elevated rates of bipolar disorder, psychosis, ADHD, OCD, and eating disorders. And the fact that these disorders co-occur is problematic because once they're established, each serves to maintain and exacerbate the other. There are also many people who experience symptoms of disorders but don't necessarily meet the criteria for a diagnosis of a disorder. And this means that many people can still have their lives disrupted by symptoms of mental health disorders without necessarily meeting the criteria for a diagnosis. So in other words, they might fly under the radar of some services. Not only do people with comorbidity experience symptoms of their mental health and substance use disorders, they also have complex presentations which can complicate their treatment and recovery. And research has shown that people with mental or substance use disorders die an astonishing 20 to 30 years earlier than the general population and spend the last 10 years of life living with disabling chronic illnesses. So there are several possible ways that comorbidity can occur. In some cases, the AOD use disorder can come about as a result of repeated AOD use to relieve or cope with mental health symptoms. And this is often described as a self-medication hypothesis, in that substances are used in an attempt to medicate mental health symptoms. In these circumstances, mental health conditions may become more apparent after the AOD use has ceased. Alternatively, AOD intoxication or withdrawal can induce a variety of mental health symptoms and disorders such as depression, bipolar, anxiety, obsessive-compulsive, or psychotic disorders. And in the majority of cases, these effects eventually subside and disappear with abstinence. But for some people, symptoms can continue even after they've stopped drinking or using substances. If one condition has an effect on an intermediary factor, which then increases the likelihood of developing a second condition, an indirect causal relationship is said to exist. So, for example, research has shown that early onset AOD use reduces the likelihood of finishing high school, entering tertiary education, and completing tertiary education. So poor education may lead to difficulties in later life, such as employment, which can then lead to other problems such as depression. And then the reverse is also possible, where a depressive disorder may make it more difficult to complete work and study commitments, which can then in turn lead to difficulties finding employment and then increase the risk of AOD use. The co-occurrence of AOD and mental health conditions can also come about due to shared biological, psychological, social, or environmental risk factors. So in other words, the factors that increase the risk of a person developing one condition can also increase the risk of developing the other. So for example, both AOD and mental health conditions have been associated with lower socioeconomic status, cognitive impairment, the presence of conduct disorder in childhood, and antisocial personality disorder. It's also possible that genetics plays a role. So in terms of what this means, although establishing the order of onset between conditions can be really useful in terms of understanding the relationship between conditions, once comorbidity has been established, it's most likely that the relationship between them is one of mutual influence rather than there being a clear causal pathway. And irrespective of what order the conditions may have developed, the strategies used to manage them are the same. So just to quickly sum up what we've covered so far before I move on, we know that comorbidity is common and can complicate a person's treatment and recovery. Once comorbidity has been established, it's most likely the relationship between conditions is one of mutual influence. And irrespective of what order the comorbid conditions have developed, the strategies used to manage them are the same. So I'll talk a bit now about the holistic healthcare approach. We know that people with comorbidity are at particular risk of developing cardiovascular disease due to high rates of smoking, overweight, obesity and diabetes, poor diet, physical inactivity, high alcohol consumption, and the use of some antipsychotic medications. So research has highlighted the need for interventions that focus on overall well-being, including reducing smoking, improving dietary habits, increasing physical activity, and improving sleep patterns. So from an AOD worker's perspective, remembering that physical and mental health are fundamentally entwined and focusing on overall well-being by providing a holistic health response and taking steps to manage clients' physical and mental health is likely to lead to improved outcomes. Some service providers are reluctant to address multiple health behaviours because of the belief that making too many lifestyle changes can undermine a person's recovery from AOD use. And although this is particularly evident in relation to smoking cessation, the view is not necessarily supported by the evidence which really supports the use of multiple health behavioural changes. So some strategies to help AOD workers overcome some of the barriers associated with these behavioural changes include helping clients minimise the physiological symptoms of nicotine withdrawal with nicotine replacement therapy or NRT, and being mindful of the different doses, the potential for NRT to interact with the metabolism of different medications, and the contraindications for NRT. Using the Australian dietary guidelines to help clients develop healthy eating patterns, or using the food spending structure, which links household budgets to food groups. The food and activity diary, and devices that track physical activity, such as pedometers, heart rate monitors, fitness trackers as motivational tools, as well as healthy sleep habits. And the broad focus of a holistic approach is really centred on delivering the right services to the right person at the right time, which means that AOD workers' roles include involving multiple services in a coordinated, client-centred approach. And this approach means that health workers should also be prepared to not only address the mental and physical well-being of their clients, but also involve and partner with other services that can provide complete individualised care. So I'll talk a bit about identifying comorbidity. So despite the high rates of mental health conditions among clients of AOD services, the detection and treatment of these coexisting problems is usually low. And that's why it's really important to screen all clients systematically and assess for such problems. Awareness of co-occurring problems will assist with the management of more complex presentations and with treatment planning. And of course, to identify problems accurately, there might be a need to involve professionals that are trained and experienced in differential diagnosis. Screening can help identify the potential need for formal psychiatric assessment. And multiple assessments conducted throughout treatment can take into account changes in symptoms over time and then be fed back into the treatment process. So 3 elements that can be really helpful in identifying comorbidity and that I'll talk about today include screening, assessment, and case formulation. So screening identifies the symptoms that are typical of disorder and highlights the need for further assessment. Ideally, screening should be conducted after a 2-week stabilisation period, but in practice, it can be really difficult in AOD treatment settings for such periods to occur. So as such, workers really need to be aware of the potential for false positives, which can occur if clients are screened during periods of acute intoxication or withdrawal. And to avoid the possibility of misdiagnosis or false positives, multiple assessments should be conducted over time. Some instruments that AOD workers might find useful include the Camberwell Assessment of Need Short Appraisal Schedule, or the CANSIS, the Kessler Psychological Distress Scale, or the K10, and the Depression Anxiety Stress Scale, or the DAS. The Kansas P, K10, and the DAS-21, and their scorers can be accessed in the comorbidity guidelines. So the Kansas is a widely used measure which assesses need across 22 domains, including accommodation, food, self-care, capacity to look after the home, daytime activities, physical health, psychotic symptoms, mental health and treatment, psychological distress, risk to self and others, AOD use, social relationships, childcare, education, transport, budgeting, and benefits. And the short form measure, or the Kansas P, is for clients to self-complete, is rated on a 3-point scale of no need, met need, or unmet need. And no staff training is required to use or score it. The Kessler Psychological Distress Scale, or the K10, is widely used, simple self-report measure of psychological distress, and it can be used to identify those who are in further need of assessment for anxiety or depression. 10 questions are answered on a 5-point scale and are scored to a maximum of 50. The Depression Anxiety Stress Scale, or the DAS, comes in 2 forms, the DAS-21 or the DAS-42, and it measures depression, anxiety, and stress separately, and also taps into a more general dimension of psychological distress. Both instruments are rated on a 4-point scale, and clients are asked to self-report for the past week. And additional screening tools are located in the body and the appendix of the guidelines, and they cover a broader range of conditions than those that I've just mentioned here. Another resource which workers might find useful is Mark Deedy's 2009 review of screening and assessment tools for use in AOD settings. And this includes a really comprehensive overview of screening and assessment measures, where they can be accessed, whether there's a cost involved in their use, details of their reliability and validity in AOD settings, as well as their strengths and limitations. And it's free to download from the NADA website, and I've put the hyperlink on this slide here. So assessment involves a detailed investigation of a person's functioning, past and present, and it should be an ongoing process to take into account changes in mental health throughout treatment. Assessment also involves case formulation and treatment planning. The depth of assessment really depends on the needs of the client at the time. So for example, the amount of information that's needed for a brief intervention is going to be much less than what's needed for extensive treatment. The assessment components include presenting issues, AOD use history, medical history, risk assessment, psychiatric history, trauma history, mental state, readiness to change, family history, criminal history, current situation, strengths and weaknesses, personal history, and a source of referral. And the process of case formulation will gather and organise all of the information from the assessment to address what problems exist, how they developed, and how they're maintained. And then generate a hypothesis as to how all of these factors fit together, form the current presentation of client symptoms, and then inform treatment planning. In addition to the dimensions from the assessment, consideration should also be given to the client's age, their sex, sexual orientation, ethnicity, spirituality, socioeconomic status, and cognitive abilities. So it's also really important to differentiate between substance-induced and independent mental health disorders. So symptoms of mood, anxiety, and psychotic disorders can all be induced as a result of AOD use or withdrawal. So for example, AOD use and withdrawal can induce symptoms of depression or anxiety. Manic symptoms can be induced by intoxication with stimulants, steroids, or hallucinogens, and psychotic symptoms can be induced by withdrawal from alcohol or intoxication with amphetamines, cocaine, cannabis, or LSD. So to differentiate between substance-induced disorders and independent mental health disorders, you can ask the client, ask whether the client has any current mental health symptoms such as depression, anxiety, or psychosis, whether they've experienced these in the past, whether they've ever been diagnosed with a mental health disorder. If the client has experienced mental health symptoms or has been diagnosed with a mental health disorder, ask about the timing of these symptoms. So when did the symptoms start? Did they start before AOD use? Did they only occur when the person is intoxicated or withdrawing? Have the symptoms continued even after a period of abstinence of about a month? Do the symptoms change when the client stops using substances? Do they get better? Do they get worse? Or do they stay the same? Is there a family history of the particular mental health condition? If symptoms occur only in the context of intoxication or withdrawal, it's likely that they're substance-induced, and they'll resolve after a period of abstinence without the need for any direct intervention. But having said that, it's still really important to manage the symptoms to prevent the client from relapsing. If mental health symptoms have started before the onset of substance use, if the symptoms persist even during periods of abstinence, or if there's a family history of that particular mental health condition, the client might have an independent mental health condition. It can be really difficult as well to distinguish substance-induced psychosis from other psychotic disorders. And if a person has experienced symptoms of psychosis, if they're experiencing current symptoms of psychosis, it may not be possible to elicit information that will help assess the onset of symptoms, family history, AOD use, and so on. But some substance-induced symptoms may help differentiate between substance-induced psychosis and independent psychotic disorders. So substance-induced symptoms tend to appear quickly. They usually last a shorter time until the effects of the drug wear off, although they can, for some people, last longer. And visual hallucinations are more common in substance withdrawal and intoxication than in primary psychotic disorders. Some of the common symptoms of low-level crystal methamphetamine-related psychosis include suspiciousness, guardedness, and hypervigilance, such as constantly being on the lookout for threats. Overvalued ideas, which might be ordinary events which have special meaning or significance. Illusions or misreading the environment, such as seeing a shadow that looks like a person walking into a room, or a random sound sounding like a police siren. And erratic behaviour, which might seem like paranoid ideas, accusing others of having wronged a person, or arguing with bystanders for no real reason, or no apparent reason. Stimulant psychosis is more commonly associated with tactile hallucinations or ice bugs, and people experiencing stimulant psychosis may be more agitated, energetic, and physically strong, and may be more challenging to control in a safe environment. But they might be also more difficult to calm with sedating or psychiatric medication than independent psychosis. So again, to give a quick summary of identifying comorbidity before moving on, given the high rates of co-occurring mental and substance or mental health conditions among clients of AOD treatment settings, it's essential that routine screening and assessment be undertaken for these conditions as part of case formulation. Consider a range of factors in the process of case formulation, so not only AOD and mental health issues, but also socio-cultural factors, motivation, living situation, and medical and personal history. Full assessment should ideally take place after a period of abstinence, or at least when the client is not withdrawing or intoxicated. And consider multiple assessments conduct multiple assessments throughout treatment, as symptoms may change over time. And then provide assessment feedback to the client in a positive, easily understood way. So in terms of the evidence of managing and treating comorbidity and how to involve multiple services to deliver coordinated care, just before I talk about management and treatment, I just wanted to really quickly touch on the models of care. In terms of approaches to comorbidity, there are 4 main models in the treatment of comorbidity, which are sequential treatment, parallel treatment, integrated treatment, and stepped care. So I won't really go into detail here, but it's worth noting, although there's been a lot of discussions of models of care for people with comorbidity, there's little research available to determine which models may suit which comorbidities. And AOD workers are likely to need to make pragmatic decisions about which model is most suited to individual clients. But having said that, the idea of integrated treatment for 2 disorders has considerable intuitive appeal, and it has a lot of advantages over other treatment approaches, including it has a single point of contact so the client doesn't fall through the gaps. There are common objectives. The treatment is internally consistent. The relationship between AOD use and mental health conditions can be explored. And the communication problems between agencies doesn't interfere with treatment. So although the research is limited in this space, there is some emerging evidence to suggest that integrated treatments may be superior or parallel to sequential treatments in in terms of improving outcomes. So there's this distinction between the management and treatment of comorbidity, in that the goal of management of mental health conditions is to allow AOD treatment to continue with minimal disruption or dropout. Management strategies that are described in the guidelines provide short-term relief and control over symptoms, which is really an interim measure during AOD treatment until full treatment of co-occurring conditions is possible. The guidelines provide do's and don'ts and practical strategies for managing common co-occurring conditions. There are a range of different options for managing and treating comorbidity, and not all treatments will suit everybody. Although most AOD workers are likely to be familiar with the more traditional psychological and pharmacological approaches, these have limited evidence for comorbidity. And in the absence of specific research, it's generally recommended to use the most effective treatment for each disorder. Both psychological and pharmacological interventions have been found to have some benefit. When pharmacotherapy is used, it's generally it should be accompanied by supportive psychological interventions, with workers aware of the potential interactions between medications and other substances. And in addition to these approaches, a new addition to the second edition of the guidelines is a discussion of e-health interventions, physical activity, and complementary and alternative therapies. For most disorders, exercise and physical health interventions have been shown to have some benefit, for example with ADHD, schizophrenia, bipolar, depression, anxiety, OCD, PTSD, and eating disorders, although more research on comorbidity is needed. So I won't go into detail here, but the second edition of the guidelines discusses the evidence regarding the treatment of disorders for ADHD, psychosis, bipolar, depression, anxiety, OCD, PTSD, and eating disorders and personality disorders. And in addition, management of symptoms that may cross various disorders like anger, grief, and loss are provided. As many of you are aware, people with comorbidity often present to treatment with various issues that need to be addressed throughout the course of treatment. So for example, education and training, family situations, housing, legal issues, employment, and physical health. So we really highlight the importance of AOD services and workers developing links with a range of local services and engaging them in treatment where appropriate. In practice, coordinated care should really involve the coordinated delivery of individual services across multiple sectors, which is then perceived as a seamless service system by clients, resulting in overall improved outcomes. One of the biggest risks in the referral of clients to external services is the potential for clients to fall through the gaps and then disappear from treatment altogether. Many of you are likely to be familiar with this image or one similar to it, which represents how clinical services have traditionally adopted a siloed approach in which mental and substance use disorders are treated separately, which limits treatment effectiveness. As a result of this, people can be bounced between mental health and AOD services with little continuity or continuation of care, which and then end up falling between the cracks in the healthcare system. People with comorbidity often also have difficulty navigating their way through available services, which can be incredibly difficult to access with multiple entry points and multiple options of treatment pathways, agencies, and healthcare providers. And often by the time somebody with these disorders is ready to access treatment, they've been experiencing symptoms for many years, and it can be really challenging to be bounced and referred between services like a treatment roundabout, or be faced with a closed door. It's therefore really critical for care coordination and the referral process to focus on linking clients in with services as smoothly as possible. So the development of formal links between services regarding consultation, referral pathways, and collaboration can help with this process. In fact, coordinated care increases the likelihood that clients will receive specialised assistance where it's needed and facilitates client engagement in treatment. Evidence has linked coordinated care with improved treatment outcomes. Coordinated care has been found to prolong client retention, increase treatment satisfaction, improve quality of life, and increase the use of community-based services. So in terms of an AOD worker's role in coordinated care, although coordinated care is facilitated by an identified coordinator or case manager, they're not expected to provide all these necessary services themselves, but refer and manage the engagement of appropriate services. And then the challenge for AOD workers is in the active engagement of multiple services and service providers with a mixture of professional and non-professional support. So AOD workers are in primary positions to coordinate care and incorporate the many services that reflect the particular needs of their clients and to deliver the best quality care. Oops, I got too excited, but forgot to flick forward. Sorry about that. So to give a summary before I hand over to Jack to talk about the online training program, AOD and other mental health disorders are common. Clients with comorbid mental health disorders often have a variety of other medical, family and social problems, for example, housing, employment, welfare and legal problems. And as such, it's really important to adopt a holistic approach to the management and treatment of comorbidity that's based on treating the person and not the illness. In addition to mental health services, AOD workers may need to engage with a range of other services to meet their clients' needs, including housing, employment, education, training, community, justice, and other support services. So I'll just hand over to Jack.
Thank you, Chris. So as Lexine mentioned before, my name is Jack Wilson and I'm currently assisting in the dissemination of the National Comorbidity Guidelines. And an exciting component of this has been the development of this online program that will translate the content of the guidelines. And that's what I'll be talking about today. So before I talk about the online training program, that will accompany the guidelines, we should explain why we chose to deliver the guidelines on an online platform over traditional methods such as face-to-face teaching. So online training has the capacity to overcome many barriers of traditional training models. It provides consistent training rather than a variation of training experienced through different face-to-face trainers. There is also a reduction in delivery cycle time, and this refers to the time between learning the content and putting it into practice. So there is the capacity for health practitioners to instantly utilize any new information or skills that they have gained through the training. Online training is convenient. It's a more feasible way of teaching, and we're able to reach more people from a diverse range of settings. There is also a reduction in information overload. The viewer has control over how much information they are presented with, rather than having to keep up with that face-to-face trainer. In this case, AOD workers are able to choose which and how many modules they would like to do in one sitting. E-learning also allows us to track information on how effective the program is. Google Analytics gives us objective data on how many people are accessing the training, which modules they're accessing, and for how long. This means that we can make alterations based on that feedback and ultimately improve the program. We'll also be able to update any information when necessary. Online training is a far more sustainable method. So reflecting back on what Chris talked about, the online training program shares the same aims as the guidelines, which are to increase the knowledge and awareness of comorbidity, to improve the confidence of those working with clients with comorbidity, as well as to improve AOD workers' ability to identify mental health conditions. And I may just add that although the training has been developed specifically for AOD workers, many other health practitioners and students may find the program very useful, and it will be free for anyone to register and complete. So the training involves 11 modules representing each chapter of the guidelines, and with key learning objectives derived from those respective chapters. At the conclusion of each module, participants are presented with a quiz, which needs to be successfully completed. Modules can be completed in any order, but all modules and quizzes must be completed in order to achieve training certification. And this just comes in the form of a certificate of acknowledgement that will become accessible on the website. It's important to note that this program can be a source of continuing professional development points. And depending on the governing body, they may also be a source of active CPD points. And that is because of the quiz section. So once we enter the training program section of the website, we are provided with a page similar to this. As you can see, the modules are displayed in a clear format and they light up once they are complete. And as I mentioned earlier, the modules can be completed in any order. We think that this is a necessary feature because we understand that a lot of health practitioners may not have a lot of spare time. So it's important to access the modules that are relevant to them. While we encourage people to complete all the modules so that they can acquire all the information that the guidelines has to offer, we also realize that someone might just want to review, for instance, information on common disorders seen in AOD treatment settings. So they might just go straight to Module 3. If we move on to the quiz component of the training, research indicates that an important aspect of e-learning is assessment. For a person to retain information, they must be able to retrieve it. To reflect this, and as I mentioned earlier, we have incorporated a short quiz at the end of each module for participants to complete. Quiz questions will reflect the key learning objectives for each module, and all questions must be all questions in the module must be complete. Having said that, there will be no limit to the number of attempts for each quiz, with incorrect answers referring participants back to the relevant section of the guidelines. We think this is a really important part of the learning experience, rather than the old guess again method that you sometimes see. They can be given in this case, they can be given the relevant information which will lead to the correct answer. So here is an example of the quiz section. We have different formats of questions, from true and false, drop-down options, and multiple choice. It's also important not to include too many questions, as we don't want the people getting fatigued or experiencing an information overload. So e-learning must be interactive, otherwise it has been shown to be less effective than teacher-based learning. Having assessments makes this training interactive, but we can't just rely on that to engage participants. The training program must be interactive throughout. There must be a clear rationale for completing a course. And as Chris discussed earlier, the overall rationale is to address that gap in knowledge between drug and alcohol and mental health. But there are also clear objectives for each module, such as understanding how comorbidity occurs, or recognizing the signs and symptoms of common mental health disorders that co-occur with AOD use disorders. E-learning is also most effective when there is strong job-relevant content. And we ensure that the content in the program is based on the most up-to-date evidence. So carrying on from effective e-learning, it is important to acknowledge that static and non-interactive training is not teaching. We must adopt a multimedia approach. And there are various techniques that we can adopt to do this. Information is remembered better when it is presented in different modes, and that is why we have considered and adopted features such as animations, case studies, and narrators. We want to use organized visuals that convey information in a way that is easily perceived. We are doing this through the use of flowcharts and Venn diagrams, etc. We also want to make sure that the graphics supports the text. If they don't serve a purpose, they just distract the viewer. Finally, we want to make sure that all the information is relevant to the training program. I'll now move on to show you some examples of how we've used these techniques. So for instance, here is an example of an organized visual. It doesn't take anything away from the text, and it supports the information in a simplistic way. Here's another example, and although the following slide doesn't include a table or a chart, these images serve to lighten up the slide, lighten up the scene rather. So for information to be absorbed, there must be a mix of both texts and visuals. And while too much stimuli on the page can often overwhelm the viewer, we believe that this is an acceptable amount of stimuli for one slide. There isn't too much going on here, and as soon as this slide is displayed, the images suggest that the subject matter is on risk factors. We have also developed a number of short animations that will feature on the Guidelines website and be embedded in the training program. Each animation is in relation to a disorder commonly experienced by people in AOD treatment settings. Once the training program has launched, the animations will also be available on YouTube. Although they are directed at AOD workers, we believe that it will be beneficial to make them available to everyone. And in saying that, and as I mentioned earlier, the online training program is available to everyone. Though YouTube is a platform where the animations are likely to gain more attention. So for these animations to represent these disorders accurately, along with the circumstances involved in experiencing them, we have reached out to clinicians and people with lived experience to provide extensive feedback. We cannot thank them enough for the valuable information that they provided. In fact, it has been very difficult developing these animations because, as the viewers would know, experiences of a disorder are unique to an individual and differ in symptomology and severity. We will also be focus testing the broader training program. To ensure that our e-learning strategies are implemented successfully, we would like feedback on the length of the modules, how engaging the content is, narration, the case studies, as well as whether the learning objectives for each modules are achieved. We will also require feedback on how the training program transfers onto other devices. Tablets and mobile phones are utilized so much that they will make up a considerable portion of our registrants. To monitor the practicality and effectiveness of this training program, we have introduced a research study onto our website. So registrants will have the option to be involved in the study. If they choose to, they'll be asked several questions before and after completing the training, as well as follow-up questions via email several months down the track to see if the information was retained and whether it was used in practice. So just to sum up, we will be delivering the guidelines content through a series of modules, each involving quizzes for assessment. We are aware that e-learning programs cannot be successful without effective learning strategies to keep the viewer engaged. That's why we are adopting techniques such as the multimedia approach, which will include the use of text, organized visuals, narration, and short animations. We also want to monitor and maintain the effectiveness of the training program. And we will do this through the use of focus testing and research questionnaires. This will be an ongoing process, but we must put certain measures in place to ensure that health practitioners get the best out of these guidelines. So lastly, for those that have yet to subscribe to the online training program, You can go online to our website and register, just the link at the top there. And please don't forget to confirm the email. You can also download a copy of the guidelines from the link at the bottom of the screen. Thank you very much. I'll just hand it over to Lexine now.
Fantastic. All right. Thank you so much, Chris and Jack. That's just been, you've covered so many really complex but important topics there, and I think given some really great tips for how people working in services can really untangle some of the issues around comorbidity. So thank you for that. So what we would like to do now is open it up. We've got some time for some questions. So some questions have already come through to me, which is great. And in addition, if anyone else has any questions that they'd like to ask for either Chris or to Jack, then please send them through on your questions panel and we'll get to those. So just to begin with, Jack, just a quick thought when you were talking about getting people that you were getting feedback on the training program, which is fantastic. So do I understand that you're then going to use that feedback to make some refinements to the training program? Is that right?
Yep, definitely. So we'll use that feedback to make any kind of alterations to the online training program, and we'll kind of do that throughout as well. So we'll do that for the modules, we'll do that for the animations. And yeah, we think that's the best way to go ahead. We don't expect researchers to have all the answers, so that's why we really need to kind of reach out and get feedback from people from all kind of different sectors.
Yeah, okay, fantastic. So yeah, it's an opportunity for people to give their feedback about anything that they think needs to be improved. Yep. Excellent. Okay, that's great. And oh, you mentioned the animations. Yep. I really want to see the full animations. They look really, really cool. And I like the idea, Chris, maybe you can answer this, is the idea that I think you said you would make them available to the wider community as well. So is the idea that people that might want to understand maybe experiencing comorbidity themselves might look up on YouTube, that kind of thing?
They've been developed specifically for AOD workers, and they'll be embedded in the website. And we've had 5 developed so far on some disorders. I might keep them a surprise at the moment. Oh no, maybe we'll say. So we have, we're going to have one on psychosis. We'll have one.
You heard it here first, everyone.
One on psychosis, one on depression, one on bipolar disorder, one on comorbidity, and one on obsessive compulsive disorder. And although they will be, so they have been developed for AOD workers, they will be embedded into the website, but they'll be housed on a public site like YouTube, so they will be publicly available. So we were thinking that if people were, so members of the general public of the community, if they're looking for information on co-occurring disorders, they might come across these as well, so there is a small amount of information on there for the general public where to find help. Although, as I say, they are primarily developed for AOD workers.
Fantastic. Well, it's a really, it's a really innovative way to communicate, and I look forward to seeing them. So that would be great. Okay, so we've got some really important questions coming through now. One is, Jack, could you go back to the slide before this questions and comments slides, just so people can get down that website for the the training package. So thank you for pointing that out. And so we've also had a question about how to obtain a hard copy of the guidelines.
Oh, yes. Sorry, I don't have my email address on there, but I should have. If you just email me at, Lexine, is there a box that you can write that in? My email address send it to everybody. Sorry, that's my mistake. It's c.marel@unsw.edu.au. You just email me with your details. I can send that out.
Okay, so that's available to anyone who requests it?
Yes, should be.
Yep, excellent. Okay, fantastic. For free?
Yes, for free.
Okay, great. Okay, so the email address.
Sorry, unless it's overseas.
Okay, Thank you. Fantastic. All right. So now another question that we have actually relates to gambling disorders. So in terms of the changes in DSM-5 and gambling disorders being listed under addictive disorders alongside substance use disorders, will gambling disorders be considered for the guidelines in any future editions?
That's a really good question. One of the things that's been really good about having developed the second edition of the guidelines was that we were able to expand on the first edition and include some conditions or disorders that weren't in the first edition. So, for example, ADHD and eating disorders. So if we were to do this again and have a third edition, I would love to expand them again and talk to people about including something like gambling disorders, and yeah, it would be something that we could definitely talk about.
Okay, fantastic. And I guess related to that is, so these guidelines, if I've understood, developed focusing on comorbidity, but for AOD workers as the target population. So are there plans to sort of do the reverse of that? So guidelines for people that are working more primarily in mental health services?
I would love to do that. It's something that we've talked about several times, and I think that these guidelines have been used in mental health settings. So they're already being used in that capacity, but they're not specifically designed, they have been developed for that reason. It would be great if we could do that, and we haven't been successful in obtaining funding so far to do that, but is anybody there who wants to give us some to do it? We're receptive to doing it. Yeah, we'd love to do it. So we'll look for opportunities to do it in future, yeah.
Yeah, well, so I could see how the current guidelines would be really useful for people working in mental health services, but I guess where the gaps are in terms of that knowledge, that real specific knowledge about managing AOD that people might not have.
There's a lot of assumed knowledge in these guidelines about what AOD use and disorders are that is not really discussed here, that I think could be expanded on in those kind of guidelines.
Okay, fantastic. So just a general comment to some of the questions that we will be emailing out the handouts, the slide handouts after the session, and also a recording of the session. So if your colleagues have missed the session, they can watch it after the fact, but they didn't get to ask questions. Now, just another question. We've just been talking about funding, and I know this is probably something, Chris, that's bigger and really beyond your capability. But I do have a question that's asked if you have any thoughts about funding models and the fact that this is an issue when we're talking about integrated care. So, for example, that funding often stops working. Funding issues stop the integrated care model working well. Do you have any thoughts on that at all?
You mean stops is a like a barrier to delivering care?
I would assume so, yes. I guess that funding, okay, so if the person would like to clarify their question, please do send it in, and you can also email Chris directly after the session. But I would assume that the question is around the fact that delivery of integrated care is limited by lack of funding and the way services are set up.
Yes. I completely, yes, I totally understand what you're saying and agree that it's, the structure is a real challenge to manage and work with. I think that for frontline workers, it really, in large part, depends on making really close links with people on the ground who are also frontline workers, and I guess doing what you can. But if you're talking about funding, like getting funding in the first place, that's a real challenge. It might be something that I have to think about.
Yeah. Okay. Well, I think, as I said, I think it's an issue that's bigger than you or me or this webinar. So it's just one of the challenges that we're facing. But I guess what's really nice about the guidelines is that you're providing the people on the ground with skills to be able to do what they can given the limited resources and system structures that might be available, which is great. Okay, so now the last question, and I hope that I have, and I hope this isn't a no question, but just in terms of when we could expect the comorbidity training package to be available. So I know we've got a lot of people tuning in from services and some tuning in groups as well. And I guess who are probably wondering when can we look forward to this being launched?
Oh, sorry, Jack.
Go ahead. No, you go.
I was just going to say that we are hoping to complete it at the end of June, beginning of July, but it really depends on the Department of Health, who are our funders, signing off on it, and it's up to them when they want to launch it. But if you subscribe to be notified, you'll be the first to know. Or if you'd like to keep in touch with us beyond that, you're totally welcome to. We're happy to keep in touch with you. Did you want to add anything to that, Jack?
No, you pretty much covered it all.
Sorry, Jack, I didn't mean to cut you off.
No, that's fine. No.
Okay, fantastic. So subscribe to be the first to know when it's launched, and in the meantime, there's the comorbidity guidelines available online and hard copies to learn from, I guess. Okay, fantastic. Well, thank you so much, Jack and Chris, for taking time to talk to us about the comorbidity guidelines today, and also to answer all these questions. And just to give a last quick plug for the next webinars that we have coming up over the year. So we do have very soon, in a few weeks away in May, we have a prevention-focused webinar about what parents can do to prevent teenage substance use, and you can register for that right now by clicking the link that will be in your slides, or going to our website, comorbidity.edu.au/training/webinars. And then another webinar in September, which will be Associate Professor Francis K. Lamkin, and talking, I guess, very well aligned with this webinar, actually. So drilling down into that more management side of comorbidity and looking at the evidence for effective models of care for comorbid presentations. And we also have a whole 11 topics that are available online. So the recordings, well, actually now we'll have another one. Now we'll have 12 available online, the recording to access, and also the handouts. So if you visit our website, you can look at the full series. So thank you very much again, everyone, for joining us for the webinar. Thank you to Chris and Jack for presenting for us, and we look forward to seeing you at one of our future CREMS webinar events. Thank you, everyone.
Thank you.
Thank you.